Welcome again everyone. Today's lesson is about Otitis Media. The term Otitis Media has two main categories. The first one is acute infection, which is termed suppurative or Otitis Media or acute Otitis Media, and the second is inflammation accompanied by middle ear effusion, which is termed as non-suppurative or Otitis Media with effusion. These two main types of Otitis Media are interrelated, and acute infection usually is succeeded by residual inflammation and effusion that in turn predispose children to recurrent infection. Middle ear effusion is a feature of both acute Otitis Media and of Otitis Media with effusion, and it is an expression of the underlying middle ear mucosal inflammation. Middle ear effusion results in conductive hearing loss associated with Otitis Media. Several factors affect the occurrence of Otitis Media, including the first one is age. The highest rate of Otitis Media is at 6 to 20 months of age, and after the age of second year, the incidence and the prevalence of Otitis Media decline progressively. The most likely reason for the higher rates in infants and younger children include less well-developed immunologic defense and less favorable eustachian tubal factors involving both the structure and the function of the tube. When we see the second risk factor, gender is another. Incidence of acute Otitis Media is greater in boys than in girls. And the other is about genetic background. The degree of concordance for the occurrence of Otitis Media is much greater among monozygotic than among dizygotic twins, which shows there is some genetic risk factor for developing Otitis Media. The other is tobacco exposure. Tobacco smoke exposure is an important preventable risk factor in the development of Otitis Media. The other is exposure to other children. Otitis Media is more common with repeated exposure to other children, whether at home or in out-of-home group, such as daycare. And the other is low socioeconomic status. Elements contributing to the association of poverty with Otitis Media include crowding, limited hygienic facilities, suboptimal nutritional status, limited access to medical care, and limited resources for complying with prescribed medical regimens. The other is unable or not breastfed. Breast milk feeding is protective against Otitis Media compared to that of formula milk. This protective effect is attributable to the milk itself rather than to the mechanisms of breastfeeding. In keeping with the pattern of occurrence of upper respiratory tract in general, highest rates of occurrence of Otitis Media are observed during cold weather months and its lowest rates during warm weather months. So season is another risk factor for developing Otitis Media. The other is congenital anomalies. Otitis Media is universal among infants with unrepaired palatal clefts, and it is also higher preventable among children with some mucosal cleft palate and other craniofacial anomalies and Down syndrome. The common feature in these congenital anomalies is a deficiency in eustachian tube function, which predisposes these children to middle ear disease. Other factors include pacifier use. Some suggest also association of Otitis Media with bottle feeding in the recumbent position, and some immunodeficiency conditions such as retroviral infections are associated with high risk of having Otitis Media. When we see etiology, acute Otitis Media is mainly caused by three pathogens. Those include strep pneumonia, non-typeable Haemophilus influenza, and Moraxera cataralis. The overall incidence of these organisms has changed with the use of the conjugate pneumococcal vaccine. And less common pathogens include group A Streptococcus, Staph aureus, and the gram-negative organisms. Evidence of respiratory viruses also might be found in middle ear exudates of children with acute Otitis Media, either alone or more commonly in association with pathogenic bacteria. Of these viruses, rhinovirus and RSV are found most often. Viral pathogens have a negative impact on eustachian tube function. It can impair local immune function and increase bacterial adherence, and also viral infections of eustachian tube can change the pharmacokinetic dynamics, reducing the efficacy of antibacterial medications. When we see the etiology of Otitis Media with effusion, using standard culture techniques, the pathogens typically found in acute Otitis Media are recoverable in only 30% of children with Otitis Media with fusion. Biofilms of pathogenic bacteria are present in the middle ear mucosa and adenoid pad in most children with chronic otitis media. Biofilms consist of aggregate and adherent bacteria embedded in an extracellular matrix and in neutrophilic extracellular traps, allowing for protection against antimicrobials, and their presence may contribute to the persistence of pathogens and their recalcitrance of chronic otitis media to antibiotic treatment. When we see pathophysiology of otitis media begins as an inflammatory process following a viral upper respiratory tract infection. Due to the constricted anatomical space of the middle ear, the edema caused by the inflammatory process obstructs the narrowest part of the eustachian tube, leading to a decrease in ventilation. This leads to a cascade of events resulting in an increase in negative pressure in the middle ear, increasing exudate from the inflamed mucosa and buildup of mucosal secretions, which allows for the colonization of bacterial and viral organisms in the middle ear. The growth of these microbes in the middle ear then leads to suppurity and eventually frank purulence in the middle ear space. When we see clinical manifestations of otitis media, in young children, evidence of ear pain might be manifested by irritability or change in sleeping or eating habits, and occasionally holding or tugging at the ear. Pulling at the ear alone has a low sensitivity and specificity for otitis media. Fever may also be present and might occasionally be the only sign. Rupture of the tympanic membrane with purulent otorrhea is uncommon, and systemic symptoms and the signs associated with upper respiratory tract infection also occur. Occasionally, there might be no symptoms and the disease having been discovered at the routine health examination. Otitis media with fusion often is not accompanied by overt complaints of the child, but can be accompanied by hearing loss. This hearing loss might manifest as changes in speech patterns, but often goes undetected if unilateral or mild in nature, especially in younger children. Balance difficulties or disequilibrium can also be associated with otitis media with fusion, and older children might complain of mild discomfort or a sense of fullness in the middle ear. When we see examination of tympanic membrane with otoscope, important characteristics of the tympanic membrane consists of contour, color, translucence, structural changes, if any, and the mobility. So we should have to see those things on otoscopic examination. The normal tympanic membrane, as you see on the image, is in the neutral position, neither retracted nor bulging, pearly gray, and translucent and responding briskly to positive and negative pressure, indicating an air-filled space. In acute otitis media, as you see on the image, the tympanic membrane may be erythematous or normal, and there might be fluid in the middle ear space. In suppurative otitis media, there will be obvious purulent fluid visible and the bulging tympanic membrane. The external ear canal may be somewhat edematous. Those significant edema should alert the clinician to suspect otitis externa, because outer ear infection is treated differently. If there is an intact tympanic membrane and a painful erythematous external auditory canal, ototopical drops should be added to treat acute otitis media. So in acute otitis media, bulging tympanic membrane and erythema and also air fluid level can be seen. Retractions or perforations of the tympanic membrane may be a sign of cholesteatoma formation. Of all the visible characteristics of the tympanic membrane, mobility is the most sensitive and specific in determining the presence or absence of middle ear fusion. When a perforation is not present, substantial impairment of mobility is the more common finding with middle ear fusion. Bulging of tympanic membrane is most specific finding of acute otitis media, but has lower sensitivity. Children's ears are self-cleaning because of squamous migrations of ear canal skin. Parental cleaning of cerumen with cotton-tipped swabs often worsens cerumen impaction by pushing cerumen deeper into the canal, compacting it. And if the tympanic membrane is obscured by cerumen, the cerumen should be removed. This can be accomplished through direct visualization using a headlight or through the surgical aid of otoscope by using an ear curate or gentle sanction with number 5 or 7 French ear sanction tube. When we see diagnosis of otitis media, a diagnosis of acute otitis media according to the American Academy of Pediatrics guideline should be made in children who present with moderate to severe bulging of tympanic membrane or new onset otorrhea not caused by otitis externa, mild bulging of the tympanic membrane and a recent onset of ear pain or intense tympanic membrane erythema. A diagnosis of acute otitis media should not be made in children without middle ear effusion. Acute otitis media and otitis media with effusion may evolve into the other without any clearly differentiating physical findings. Any schema for distinguishing between them is to some extent arbitrary. In an era of increasing bacterial resistance, distinguishing between acute otitis media and otitis media with effusion is important in determining treatment, because otitis media with effusion in the absence of acute infection does not require antibiotic therapy. The other is conjunctivitis associated with otitis media. Simultaneous appearance of purulent and erythematous conjunctivitis with an ipsilateral otitis media is a well-recognized presentation caused by non-typable Haemophilus influenza in most children. The disease often is present in multiple family members and affect young children and infants. Topical ocular antibiotics are ineffective and oral antibiotics effective against resistant form of non-typable H influenza should be given in such case. Regarding treatment of otitis media, once the diagnosis of acute otitis media is established, the goal of treatment is to control pain and to treat the infectious process with antibiotics. Non-steroidal anti-inflammatory drugs or acetaminophen can be used to achieve pain control. And if there is clinical evidence of suppurative acute otitis media, oral antibiotics are indicated to treat this bacterial infection, and high-dose amoxicillin or a second-generation cephalosporin for 10 days are first-line agents. If there is a tympanic membrane perforation, treatment should proceed with ototopical antibiotics safe for middle ear use such as ofloxacin rather than systemic antibiotics, as this delivers much higher concentration of antibiotics without any systemic side effects. In case of penicillin allergy, azithromycin or clarithromycins are a first line of treatment if there is penicillin allergy. Other options for penicillin allergic patients are cefdinir, cefodoxime, or cefuroxime. And for those patients whose symptoms do not improve after treatment with high-dose amoxicillin clavulanate should be given for 10 days. In children who are vomiting or if there are situations in which oral antibiotic cannot be administered, ceftriaxone 15 mg per kg per day for 3 days, either IV or IM is an alternative option. Patients who have experienced 4 or more episodes of acute otitis media in the past 12 months should be considered candidate for laryngotomy with tube placement according to AAP guideline. Recurrent infections requiring antibiotic clinical evidence of Eustachian tube dysfunction, and placement of tympanostomy tube allows ventilation of the middle ear space and the maintenance of normal hearing. Furthermore, should the patient acquire otitis media while a functioning tube is in place, they can be treated with ototopical antibiotic drops rather than systemic antibiotics. When we see management of otitis media with effusion, otitis media with effusion generally resolves spontaneously with watchful waiting. However, if it is persistent, laryngotomy with tympanostomy tube insertion is considered an effective treatment. In this treatment, a ventilation tube allows for air entry into the middle ear, preventing reaccumulation of fluid. Adenotomy is currently utilized in case of otitis media with effusion that involve enlarged adenoids and is an important addition to management in patients with otitis media with effusion. Rarely, otitis media can have some complications, and the complications are divided into intratemporal and intracranial complications. The following are intratemporal complications: hearing loss, tympanic membrane perforation, chronic suppurative otitis media, cholesteatoma, and others. Whereas intracranial complications include meningitis, subdural empyema, brain abscess, extradural abscess, and others. When we say prevention of otitis media, general measures to prevent otitis media that have been supported by numerous investigations include avoiding exposure to individuals with respiratory infection, appropriate vaccination, avoiding environmental tobacco smoke, and breast milk feeding. This is all about Otitis Media. Thank you for watching.